our CCCT monthly meeting. It's good to see you guys. I know more people are coming. So I do want to try to get right into the meat of it. But before we do that, of course, we want to welcome everybody to our meeting. And if you're new, we would like you to come off mute and introduce yourself. You're in your organization, and I know we have. I know Taylor said we have some icebreakers, but if you're new, if you could just come off, and I'll let her talk about the icebreakers. But if you're not new, if you could just introduce yourself in the chat box, or put yourself in the chat box and introduce yourself. We're going to use a lot of the chat box function because we're really going to try to get through pretty quickly today. Taylor, did you want to introduce the icebreaker now or no?
Yeah, sure. Happy 2025, everyone. Welcome back for our first meeting of the year. Hope everyone had an enjoyable holiday season. Just really quick, if there's anyone who is joining us, if you'd like to introduce yourself with your name, organization, and then our icebreaker to start us off, what are you most looking forward to accomplishing in 2025? And feel free to also use that chat function to introduce yourself and respond to our icebreaker this morning.
Hi, good morning. My name is Dr. Shatia Blunt. I haven't been a part of this meeting, but was invited by Taylor, I believe. And so I am a private practice owner, IME LLC. And I also I am a private practice practitioner, and I also do some legislative advocacy and several other things. For this year, I hope to get my bill passed. It's a law, which is the bill discussing advocating for annual behavioral health visits. It's a mental health parity bill, and I should be publishing a book. So those are the two things that I'm looking for in this season, and I'm very happy to be on the call with you all today. Thank you.
Thank you.
Good morning. My name is Denise Robinson, Executive Assistant of Community Engagement Consulting Group. I'm not new, but I'm still considered new because this is my second meeting with you guys. Happy New Year. I'm learning what CCG is doing. I am familiar with the nonprofit sector from the Mission Love Charities Incorporated for over 20 years. But I'm here just to learn and see what part CCG can play with the CCC monthly meeting as well, and the other nonprofits that's involved.
Thank you. Anyone else? Okay, well, we're going to go right into the agenda, and because we have very interesting partner presentation from HQI, and I really been looking forward to hearing about the results of this. This was a lot of hard work that went into this work with our CHW workforce, and it reflects on the efforts that have been done in Prince George's County, which I am very proud of. So I want to be sure we get right into that. Also, of course, we're going to have community announcements, and then we'll adjourn the meeting. Now, as we always do in our CCCT meeting, we put up our vision and mission statement, because that's important for you to know, especially in these times, because what our goal and our vision has always been to make Prince George's County that place where you can access high quality and effective healthcare services that are well managed. And that's one of the things that CCCT really wants to focus on, and it's tailored to the people's specific needs. And I like this vision because it doesn't have any language that anybody can get offended by, which in these days and times is really, really important. The second thing about our mission and our mission statement is it talks about empowering healthier lives and effective care through coordination using strategic systems approach. And that, again, is the language we have to use moving forward, because the CCCT is specifically focused on how we can disrupt the system that's not allowing our people who really need services to get services and improve their healthcare outcome. We're going to do that, and we're committed to do that. And especially the folks in Prince George's County has always been pointing in this direction. What the CCCT is going to provide is the guides to do that. And what we're going to talk about today is a component part of what we've been trying to achieve all along. And this is to figure out how to have a sustainable community health worker workforce so that we can empower our care coordination in this community, in our community. So without further ado, I'm going to hand it over to Twanisha to introduce our partner presentation.
Hi, good morning, everyone. And I'm gladly ready to present to you two outstanding speakers who we work closely with on several projects, including Prevention Link, CHIS, and other initiatives with in the health department. So with that being said, I'd like to introduce Tammy Ofamile. If I'm pronouncing your name wrong, I apologize, and please correct me. Tammy is the healthcare manager at Health Quality Innovators. Tammy is committed to advancing healthcare through advancing equity and eradicating health disparities. Prior to joining HQI, she serves as a data analyst at the Massachusetts Health and Hospital Association, where they manage diversity, equity, and inclusion surveys to help hospitals highlight where they can make improvements. Also, she serves as a research assistant at the Disparity Solutions Center at Massachusetts General Hospital. There, they conducted research on strategies to reduce disparities and support the hospital's strategic plan for DEI. Tammy also holds a Bachelor of Science degree in Neuroscience and Health Equity Studies from Urus College. Welcome, Tammy. We look forward to hearing from you. And then also, I would like to introduce Catherine Zapak. She's a senior consultant manager at HQI. She leads the population health and IT consultant line, supporting consultants working across the healthcare continuum, focusing on improving clinical outcomes, practice efficiency, health equity, chronic care management, and community partnerships. Additionally, she managed Turning the Tide of Diabetes, a CDC-funded program aiming to build capacity to deliver and sustain culturally appropriate diabetes education and prevention programs, while also identifying and addressing social drivers preventing patients from program enrollment and completion. Her prior experience includes supporting health systems, federal qualified health centers, and mental health providers, participating in the Richmond Accountable Health Community to administrate quality and equitable social needs, screening, and resource navigation services. Catherine currently serves on the Virginia State Health Commissioners Advisory Council and on health disparity and health equity. Welcome, and we look forward to the presentation.
Thank you, Tanisha. I know Tammy's going to share a slide deck. So thank you for the introduction. And as Tanisha said, Health Quality Innovators has worked with Prince George's County for many years on various projects. So we are happy to support you with this sustainment journey for CHW. So Tammy, if you want to go to the next slide. All right, so just to level set, you may already know this, may have this memorized, but a community health worker is a frontline public health worker who serves, who lives in or is trusted by the community in which they serve. CHWs are really that connection between the health system and social service system and the people they intend to serve. They help basically help shepherd folks through all of these nuances and systems and the minutia that really keeps people from accessing everything they need to live their healthiest and best lives. Next slide. CHWs are very versatile in that they can work in a variety of settings. They can be in the community, pounding the pavement, knocking doors, talking to folks, or they can be based in a clinical setting or a hospital setting where they are going over treatment plans and ensuring patients understand what the provider was talking about and being an advocate in that clinical setting. So with that being said, Prince George's County understood their value when it came to addressing the COVID-19 pandemic. So next slide. So you may have heard of CHIS, or the Community Health Integrated Service Systems, which is a CDC-funded grant held by the county that was meant to combat inequities in Prince George's County related to COVID-19. Seeing what CHWs do and then seeing the populations that were most impacted by COVID, it made sense to bring CHWs on board to go to those populations, so where they convene, where they live, where they work, to educate them about COVID and about the vaccines that were available to them. But understanding that you can go to someone's front door, talk to them about COVID-19 and talk to them about the vaccine and then get them on board to get it. If it turns out they don't have transportation to get to the vaccine site, or they have some other health conditions where they need to understand if the vaccine was the right decision for them, CHWs could help them address those unmet health and social needs in order to appropriately approach COVID and the vaccine. Next slide, please. So the overall program goals, as I mentioned, was addressing folks that were in areas with high COVID transmission but low vaccination uptake. And a big portion of the CHIS work was recruiting, training, and certifying community health workers to be deployed to do this work. I'm not going to read every single program goal, but the thing that brought us here today in HQI to the table in this last year of the grant was to identify ways to sustain CHWs when this funding ends in August. So next slide. So the focus is, or the focus for HQI as well as for the county in this last year of the grant is identifying financial sustainability for CHWs of the county. We want to move away from grant dependency. While there have been a lot of great grant opportunities from the federal government and private funders to sustain CHWs and get their services out there, we know grant funding is not always constant. We know the dollar amount can change. We also know the will of the grant maker can change too. 10 years from now, they may have a different focus because they should be expecting us to sustain CHWs. So we're looking at other paths outside of grants. The other part of sustainment is related to professional growth of CHWs and retaining CHWs. While we all recognize CHWs are valuable, I think there's this lack of career ladder for CHWs to have leadership roles and to do more with their training and their knowledge base. So the other part of CHW work, it can really be difficult, right? We see a lot of burnout with CHWs. So we want to make sure that CHWs have what they need to be well and healthy in their role, and also have that support to continue on in their role. So we kind of have these two things we're focused on when it comes to sustainability, but Tammy is going to go into the environmental scan and what we've found out. But I just want to say that the county has done a tremendous effort when it comes to starting up CHIS and getting CHWs out in the community. I think it's a big effort when it comes to onboarding CHWs during a public health crisis and then trying to navigate that plus new staff members. So I commend the county for the work they've done so far, and also commend them for saying, okay, look, let's take a step back. Let's see what we're doing well. Where can we improve so we can truly sustain our CHWs moving forward and provide the best services for people in the county who need them. So give yourselves a pat on the back for that. So with that, Tammy, I think you're up next.
Hello, everyone. So I'm going to start with an overview of our environmental scan. We aim to understand the various avenues that the county could pursue to sustain CHWs, just as Catherine was sharing. And so this section of the presentation is going to be broken down into these 4 areas. The first 2 are interviews with the placement organization partners, as well as the CHWs. Then we'll look into funding models and billing pathways. So we'll begin with the interview summary from the CHIS placement organization partners. HQI staff conducted interviews with PGCHD's 3 subcontracting partners, Casa de Maryland, Total Linking Care, and HCDI, all of which were responsible for hiring, supervising, and placing CHWs at various locations across the county. So the purpose of these interviews was to understand how the organizations recruited, trained, and supported their CHW workforce, as well as to understand their own plans for sustainability at the end of CHIS funding. So all partners reported that an overall lack of available community-based resources in the county was a source of frustration for their CHWs. So because of this, they were often creating their own community resource inventories for their CHWs to use in the field. But none of these organizations cited sharing their resource inventories with others. So to maintain consistency in resources provided to community members, as well as to enhance CHW job satisfaction, we recommend that the county maintain one community resource inventory for all CHWs working on the county funded programs. So this would reduce duplication efforts and provide consistency in both resources and information. And this could also create continuity across current and future work. And alternatively, the county could also engage a third party to maintain a resource inventory, but it's also important to note that that would require some additional funding to create and maintain. Another common challenge that 2 of the sites reported was having to conduct additional training for their CHWs beyond what was the minimal criteria for CHW certification requirements. So this included being trained in outreach methods to community members, how to respectfully interact with community members from different backgrounds and cultures, as well as how to provide trauma-informed care. And so a recommendation for consideration is to offer training opportunities to align CHWs across the county on various initiatives, potentially mobilizing CHWs to support county initiatives and programs without having to formally represent those programs. So in terms of sustainability, 2 of the 3 organizations were not concerned about sustaining their CHWs after the CHIS grant ended. One noted that it has CHWs working in other capacities across its organization, and so they were confident that they could place any of the CHIS CHWs on other projects or offer other opportunities within their organization. Another funds their CHW workforce through various grants, so they're not currently concerned about future funding due to their current funding streams, as well as the continued demand for CHW services. And then lastly, another organization is exploring billable pathways, such as cross-training their CHWs as National Diabetes Prevention Program lifestyle coaches, which enables the CHWs to bill for duties performed as lifestyle coaches. And they're also exploring another pathway through the Medicare physician fee schedule, which we'll talk more about later in this presentation. So the next part of the environmental scan I will be highlighting is the CHW interviews. So from September to November of 2024, we conducted a series of 8 interviews with the PG County CHWs to better understand their experiences and their roles. So the interview focused on several of the areas that you can see listed here, from career goals to barriers and challenges, how CHWs cope with difficult cases, job growth and security, and so on. So I'll be going through some of the main highlights from the interviews. So to start, as an overview across all interviewees, the average length of time working for the county was 2.97 years, with an average length of employment as a CHW being just over 3 years. 7 out of the 8 interviewers began working as a CHW when they started with the county. CHWs have worked in a variety of venues, such as community food distribution centers, food pantries, the library, library, churches, community centers, clinics, and hospitals. In terms of career goals, CHWs expressed interest in moving into higher positions, such as case management or supervisor managerial roles, using the CHW role as leverage for a career in nursing, continuing to connect clients with necessary resources, and becoming more of an advocate for underserved communities. These next few slides, I'll be talking a little bit about some of the barriers and challenges that CHWs are facing. So the first has to do with the outreach events. There are CHWs shared that sometimes outreach events can be disorganized, and there's a bit of miscommunication that happens between the event hosts and the health department, which has at times led to CHWs arriving to events where event hosts were not aware that they were supposed to be there. So this causes them to either have to be sent away and go home, or kind of quote unquote make do and figure out a place to put a table. CHWs also noted that there are sometimes issues with the weather conditions, especially during the winter when it's rainy and cold. So one CHW shared that being provided tents or other accommodations to protect from the weather would be helpful. And then at some community events that they attend, there's a lack of signage about CHWs being present. And others stated that at times it doesn't feel quite like people are looking for CHWs or need their resources. So ways to highlight to the community the purpose and the resources CHWs can provide when they're at these outreach events would certainly be helpful. Another theme that came up was incompatible site placements. There's some incompatibility at times, such as non-Spanish speaking CHWs getting assigned to sites in areas of the county that are largely Spanish speaking. CHWs also expressed that there is a lack of consideration when it comes to assigning sites. They're often given site placements a day in advance, and there's not enough time to plan. And this can be exacerbated by the distance that some of them have to commute, which can be up to 45 minutes to an hour. And so for this, we want to note that the combination of having to make the plan to travel, along with uncertain outdoor conditions, having minimal planning time, all of these things can be quite disruptive, especially if things like childcare needs to be planned for. So we really want to emphasize supporting a work-life balance for the CHWs by addressing some of these challenges. Some other themes that arose were an unbalanced work distribution. Some CHWs are contending with feeling an uneven distribution of work for the same pay. They feel as though they are contributing more to seeing clients on a monthly basis, but are not receiving any benefits of that, leading to not feeling appreciated or it taking a toll on their mental state. Another theme was organization and coordination issues. CHWs also stated that when they first began orientation, there was some confusion around what they were supposed to be doing. Some did data entry supplies. They were made to wait for a long time. And after the orientation, they were given a certain number of resources to provide to CHIS participants, like masks and COVID tests and hand sanitizers. But for other assistance programs outside of COVID, CHWs were not informed and did not have as many resources on what to provide for residents with other needs. Such as housing and rental assistance. So they found that they themselves would have to kind of go out and pull from their own knowledge or own resources to try and find things to assist those clients. The last concern amongst the challenges was just an overall lack of resources for some residents. CHWs talked about long wait lists and limitations on how many people can access certain needs assistance programs. The next topic was around supervisor support. Several of the CHWs raised the challenges I just shared with their supervisors, and there were kind of mixed responses regarding how those concerns were received. So many feel as though their supervisors were understanding of their challenges, received them well as assisted in finding solutions to various issues. And other CHWs felt as though their concerns were not taken into serious consideration. And one of the things to note here is that some of those concerns are a bit out of the supervisor's control, such as having access to specific resources for clients. One of the other items that came up was due to the volume and the frequency of calls to clients, sometimes it's difficult for CHWs to have time to be empathetic when listening to people's stories, which can contribute to feeling a bit drained. And so the supervisors are still asking calls to be called within that 24 hours. And so CHWs would just appreciate a little bit more time in between those, emotional toll, those calls that can have an emotional toll. CHWs also brought up that communication can be difficult with supervisors on the weekends during outreach community events. And so having a better way to reach them during these timeframes would be helpful. So 6 of the CHWs stated that their salaries do not currently meet their living needs. One said the salary does meet their needs, but this is partially attributed to them living with family. And while the other one said yes, they did say, quote, "It is a little snug at times." All the interviewees noted that an increase in pay is needed to align with the rising cost of living. And then when asked about pay increases, 6 of them stated they have not received pay increases, while 2 shared that they did receive an increase when transitioning from being a summer intern to a full-time employee. In relation to benefits, most of the CHWs are not currently receiving medical insurance, paid holidays, or paid time off. The next topic here is about job growth. The interviewees shared a mixed response to whether they see job growth in their roles. Some can envision growth, while others cannot. Certain CHWs feel as though the role has pushed them to expand and grow with more responsibilities, provides the opportunity to engage in a variety of programs. It has equipped them with useful training that assists in building knowledge and skills, and it offers a way to reach a variety of individuals in need. Others, however, feel as though they could not see job growth within the department. One expressed that with higher education and experience gained over time, they should be able to step into a higher role, but they have not been given this opportunity, ultimately feeling like the CHW role has kept them in a box. Another used the phrase, they've remained in the same position for some time, while another is currently not feeling growth because they don't feel appreciated. And then there's job security here. So CHWs are concerned about what will happen when the CHIS program ends. They have experienced a lack of clear and timely communication when announcing program end dates or what work will be available next. So CHWs are currently not given a 60-day notice of program ending or if continued funding is being pursued. So for example, there was an instance where a CHW reported to a site and learned only upon arrival that that program had ended. CHWs who are contracted by a third party also feel job insecurity due to the possibility of contracts not getting renewed, with one describing it as feeling on edge. So based on the feedback from the interviews, we've come up with several recommendations. Firstly, it's certainly crucial that CHWs feel like respected and valued members of the team, making it important to uplift their role in the county department as well as on the healthcare team. An increased level of structured organization and communication when it comes to outreach events as well as directly to CHWs is certainly needed. And this can look like a standardized orientation that makes clear the role that CHWs will play, provides detailed information on the programs they're a part of, and about site placement expectations. Sharing site placements a week in advance or assigning sites that are closer to CHW's locations or recruiting CHWs from specific communities would also be helpful. Creating a tiered CHW position with salaried increases over time, as well as increased responsibility based on years of experience. This could allow seasoned CHWs to supervise other newer CHWs as a way to develop the profession, build professional skills, similar to how physicians learn from each other via residency. And then it's also important to consider CHW's own goals for their work, striking a balance between funding needs and CHW wellness, understanding the quality that CHWs can do in their work can be at times emotionally taxing. And so in order to minimize burnout, consider CHW input when structuring program goals. And then lastly, as we've stated before, creating a centralized inventory of resources for CHWs to be knowledgeable about will also be important. So we're going to switch gears here a little bit and talk about public-private partnership options for CHW sustainability. We'll start with community care hubs, or a CCH, which is a community-focused entity that organizes and supports a network of community-based organizations, providing services to address health-related social needs. They are uniquely positioned to address the various challenges that contribute to health disparities in a variety of ways, including providing support and a centralized infrastructure for organizations that employ frontline workers such as CHWs. So the Pathways Community Hub model is an example of a CCH working to improve health outcomes. They are an outcome-focused, pay-for-performance network of community-based organizations, agencies, and providers working together to build a large network of available services. So this model hires and trains CHWs from the communities that they serve to provide education, build relationships, assess needs and risks, and make connections to the appropriate services. So PCH does this by billing Medicaid Managed Care Organizations, or MCOs, along with other funding partners for services rendered by CHWs. So using this example, the county could consider approaching MCOs to offer this service to Medicaid patients, providing the costs and the savings, and essentially working out a contract that is not necessarily a covered benefit. And another example in Maryland, in Montgomery County, they have service consolidation hubs, which are a partnership of 7 organizations, including schools, CBOs, businesses, hospitals, and communities, as well as the Department of Health and Human Services, to increase food access and provide other services such as vaccines, testing, COVID kits, and community outreach. And so because PG County and Montgomery County are bordering counties and share a similar demographic makeup, there may be room for collaboration here. So while CBOs are ideal for addressing SDOH needs in their communities, most are not qualified rendering providers of care. However, it is possible for CBOs to partner together as part of a CCH network. And so this is where care coordination through a centralized network can really come in. So through a CCH, CBOs can implement a centralized referral process through a single entry point, provide comprehensive SDOH screening, create person-centered plans defining all resources that are required to meet identified needs, submit claims to a payer, and blend public, private, healthcare, and philanthropic funding, evaluate SDOH needs and implement interventions, as well as provide closed-loop reporting. So a CBO can submit claims for reimbursement of services provided by CHWs by either becoming an eligible rendering provider with payers or aligning with an existing rendering provider, such as forming a contractual relationship with a rendering provider to provide CHW support to that provider's multidisciplinary care team. An example of CBOs pooling resources together to support CHWs is the VITA Community Health Worker Program, which provides outreach, education, and wraparound services to support and prevent the spread of COVID-19 among Monterey County residents. So this program sits under the Community Foundation for Monterey County, which is a philanthropic organization, supports more than 50 CHWs across 8 organizations. And funding is pooled from a variety of sources, including the county, other CBOs, and a foundation. So following that VITA model, another option is crowdsourcing funding. A policy insight written in 2018 characterizes SDOH interventions as a type of public good that healthcare delivery and payer entities have a common interest in financing. So this policy insight introduced a model for community financing investments in SDOH called Collaborative Approach to Public Good Investments, or CAPG, where local stakeholders can invest in a common project that will be beneficial to all. So the CAPG model is implemented in 8 different steps. So it starts with a coalition of stakeholders, which are organizations that could benefit and are potential bidders, is developed according to local interests, network, and availability. Second, a trusted broker organization, essentially a third party, is identified to manage the CAPG process, acting as a confidential place of information. Next, the coalition identifies the preferred intervention that will be bid on based on local priorities and bidders' preferences. So in this case, that intervention could be the county and various healthcare organizations funding CHWs for an identified period of time. Fourth, bidders, aka the organizations involved, submit their willingness to pay confidentially to the trusted broker. And bidders' willingness to pay is kind of a statement of the project's perceived value, including both financial value as well as non-financial value, such as health improvements. Next, the trusted broker costs the project and compares costs with the sum of the bids. And if the sum of the bids is less than the expected cost, then the project is reevaluated or abandoned. But if the sum equals or exceeds the cost of the project, then it can proceed. Next, once the project is greenlit, each bidder is assigned a price that is discounted based on how much of the bids exceeded the total project cost. So this discount is effectively the kind of first installment of the return on investment that can enable this kind of financial agreement to be sustainable. Then the trusted broker receives the payments from each bidder, manages the contract with the vendor, and where applicable, updates bidders at regular intervals over the life of the project. And then finally, that broker coordinates data flows and evaluations of impact as desired by stakeholders. So overall, while this model takes a lot of coordination, it has a lot of potential to provide a way to build the financial foundation necessary to provide the kinds of sustainability for CHWs that we're seeking. And I'll pass it over to Catherine.
So Tammy mentioned the Medicare physician fee schedule final rule earlier in the presentation, and this is the only billing pathway through a payer for CHWs at this time. So this is only for Medicare beneficiaries. But what I want to highlight is that CMS, or the Center for Medicare and Medicaid Services, has realized that they need to provide some sort of services to address health-related social needs. So they have introduced kind of a 3-part program, if you will, within the physician fee schedule, and that's community health integration services, SDOH risk assessments, i.e. screenings, and principal illness navigation services. What is really exciting about this final rule is that we understand a lot of private practices, they might not necessarily have the means to hire a CHW as well as supervise a CHW to be a part of their staff. So this final rule allows Medicare providers to contract with an outside entity. So we were just talking about the community care hubs, right? Or thinking about that bidding process. So for a provider that's like, maybe I have a few folks that could benefit from these services, I can contract out and then work out some sort of payment reimbursement between the practice and the CBO that they're contracting with. But this is clearly the only path that we can see through a payer to pay for CHW services. As far as I'm aware, Maryland's Medicaid does not pay for CHW services. And then also we didn't identify any private payers in Maryland that pay for CHW services. So I'll talk a little bit about these 3 items. So next slide, please. So the community health integration services, this is designed to meet unmet health-related social needs that impact a patient's ability to receive a diagnosis or follow through on a treatment plan for some medical issues. So an example would be if I live with diabetes and my A1C is out of control and I'm not doing a great job of managing my disease, I go to my provider, they screen me for social needs and realize I am unhoused and food insecure. Then my provider can initiate these CHI services with my consent, have a warm handoff to a CHW who works with me to resolve my housing and food needs. Then I can focus on, counting carbs and taking my insulin because I now have a place to refrigerate my insulin now that I'm housed. So the great thing about these services is that CMS has realized you can't cure someone's housing insecurity overnight. So there's no cap on these services, meaning if it takes me a year to resolve my housing needs with the assistance of a CHW, and that CHW is documenting our encounters in the record and it's being appropriately billed under the practitioner, we can be reimbursed for these services. You can see the codes indicated below, as well as the national payment rates that I have here. So the rates may be different for Prince George's County. And then also in 2025, FQHCs can use these codes to bill as they had different direction in 2024. And one thing I will note for community health integration services, an individual can only be engaged in CHI services with one provider at a time. So I can't try to get my housing needs solved by going to two different providers and being in two different CHI kind of services. So you can note that. Next slide, please. Similar is the Principal Illness Navigation Services, and so this is for individuals with serious high-risk conditions that last at least 3 months, and CMS has outlined kind of examples of those conditions, but thinking about prevention-linked diabetes is one of those conditions. Again, it has to be initiated by a provider, can outsource to a CHW, build under that provider. But I think this really aligns with some of your care coordination goals, right? This is a CHW working with someone for a person-centered assessment. We're making patient-driven goals, coordinating home and community-based care. Like this is a pathway for billing for care coordination, obviously for a subset of patients, but it's income. Someone can, however, if they have more than one condition, be in Principal Illness Navigation Services for more than one condition, because what I need for my substance use disorder is probably different from what I need for my cancer treatment. So billing can go for both of those conditions. And then same kind of caveat around the billing codes for FQHCs and the facility rates. Next slide, please. So coupled with these two service lines is the SDOH risk assessment. So providers can screen no more than once every 6 months. So it's about 2 screenings a year. And those risk assessments can be administered at a variety of different appointments. However, if a provider is screening their Medicare beneficiaries and billing for this risk assessment, they need to be able to provide the community health integration services for patients that may be eligible. CMS does not see the value in you screening someone and saying, good luck to you and those needs, thanks for sharing, I'm going to collect my $8 now. So making sure those CHI services are available. So this could be something where you could approach the county, could approach providers who are like, I don't have a huge pool of patients that would need the CHI services, but you could say, hey, if you screened all of your Medicare beneficiaries and you take in that revenue and then contract with us for any CHI services you have, we could all have, benefit here. So just want to put that out there. Tammy, next slide. And I will say before I move on, the county has, as part of this environmental scan, we have outreach to 4 practices for an initial kind of survey on their interest on potentially partnering with the county for PIN or community health integration services. So that's in its early stages. So I don't have a lot to report to you right now outside of 3 of the 4 organizations were interested in following up on this and talking more with the county about their options of potentially partnering with CHW services. So as I mentioned before, Medicaid is not a current billing pathway, but there are 24 states that do pay for CHW services in a variety of different ways through Medicaid. The source that I've linked below in the slide does outline each state and what they do, and it really varies. There's some states with very generous reimbursement rates, some that I would not think are very generous, and some that have more focused programs like working with pregnant and postpartum individuals who have an opioid use disorder. Very narrow focus in West Virginia. So the other payment options, we think about bundled payments for organizations that have chronic care management services. And as Tammy outlined earlier, thinking about that dual role, maybe with a national DPP coach certification to build that way. So then thinking about, could potentially CHWs bill for DPP services through Prince George's County's umbrella hub, if that is bringing in some revenue. So just thinking about that too. Next slide. And then thinking, this might be the least popular slide, but taxes, right? If you increase taxes somewhere along the line or introduce new taxes, obviously that brings in revenue to the county that could potentially sustain CHWs. There is just an example we wanted to share from Bernalillo County out in New Mexico, where they went the mill levy route, which is basically assessing additional taxes on residential properties and other properties in the county. But the way they went around doing this was that they made it a voter approved mill levy. So they didn't just throw it out there and say, you're not paying these taxes. They presented it to their community as an investment in their community to pay for CHW services. And this is reassessed and voted on every 8 years. So the county, residents can say, we don't want this anymore at any point, but you can see the amount of money that was generated through the mill levy. So thinking for Prince George's County, maybe it's not necessarily a mill levy, and that's not maybe the best route to go, but looking through your operating budget for the county, you have special revenue funds. There's like, for instance, there's a surcharge on marriage certificates that pays for different domestic violence initiatives. Are there any other pathways through your county council that you could think about to potentially generate revenue? And I don't know how consistent or what the volume of revenue is from those marriage license surcharges, but just thinking about how much money does the county need to sustain your CHWs? Is there a tax pathway for that? And then how popular would that be and how well received? So that's kind of on you guys for that, but happy to support you in that. So Tammy, do you want to wrap up for us?
Yes. So our last few slides here, one we've mentioned earlier in the presentation, the importance of creating a centralized inventory for resources. So I just wanted to take a moment to highlight that again. We know the county is working to partner with findhelp.org to be that platform for resources. So this is a great opportunity to partner with CBOs who provide various social services and encourage them to develop detailed profiles on the site. And the site could be included in future CHW orientations as well as trainings. And lastly, we'll wrap up by talking about care coordination. We've mentioned it a couple times throughout this presentation, but I wanted to use a slide to kind of wrap up everything here. So supporting people with complex health and social needs often requires this kind of care coordination between healthcare, social services, housing agencies, CBOs, and other services and providers. So CHWs can really assist in building the strong organizational relationships required for care coordination. And this can be done by initiating new relationships and strengthening existing ones through their day-to-day work, exploring ways organizations could work together. And the Center for Outcomes Research and Education, or CORE, found that outreach done by CHWs creates more trust and communication with organizations, leading to increased referrals into a care coordination program. And so it would be necessary to allocate time and support for CHW's relationship building efforts to help treat this as a core job duty. CHWs can also improve relationships within their organizations through increasing communications across departments. And this could be with morning huddles, ongoing conversations, or other communication tools. In one of the interviews with the CHWs, one mentioned that it would be useful to have direct contact with the different agencies across the county. So this would be a great place to start in helping to strengthen that care coordination. And this can also help improve staff understanding of client and patient needs and other services that they receive. And then lastly, CHWs can act as a liaison and an advocate between clients and healthcare organizations, as they already are working in those hospital and clinic settings. So these are just some ways to think a little deeper about moving forward with care coordination. And that does wrap up our presentation, and we can move on to question and answer. Thank you all so much for your time.
Any questions? I think this was a great presentation, but before I spill my 2 cents, I'll just see if any of the participants on the call have any questions.
Hello, this is Shatia. I don't know, can you all see and can you hear me?
Yes, we can hear you.
Okay.
Yes.
So yes, thank you for a really great presentation. I heard in the presentation that the community support workers or community workers are also experiencing a bit of burnout and maybe some moral injury associated with doing this level of direct service on the job. And I was wondering if there were some recommendations on how to kind of support the overall health and well-being of these workers, given that many of their organizations are not providing insurance or benefits in that way.
Yeah, so with this work, that this kind of what we want to have happen in the future. This through the interviews, they kind of named what they would need for support, so that they don't continue on that burnout path. And some of those things are being provided with certain benefits or having a little more space between calls, between client calls, for example. So things like that are kind of the ways to build up that support over time. So that's kind of what we're hoping to recommend.
Okay. Thank
I would
you.
also just follow up to Tammy's comment and just say, as you are developing, programs, getting that CHW input of like, what is a realistic caseload? How quickly can you call people back? Not saying that you're say like, oh, call 3 people a day and that's it, but having that balance between meeting expectations of a program and then understanding that this work can be mentally exhausting.
Okay, thank you.
I have a question. Did I hear correctly that the W's are having lack of resources like housing and rental assistance and other services, resources is it for the clients?
It's for the clients, not the CHWs. A lack of resources was pertaining to helping clients.
Right. I know in Prince George's County, we do have resources for housing and rental. Of course, the list is as long as our arms, and other resources in the Prince George's County. Do you provide a list, so the list can be provided for them, or some type of documentation?
So that's a bit about what we hope to recommend. And just as what you're saying, I think with the housing and rental assistance, it's not completely that those resources aren't there at all. It is that they already have such long wait lists.
Right.
So the current clients are not able to access those in the same way.
Okay.
So I think that's why one of our recommendations is to create some kind of central resource bank so that there is kind of a one-stop shop for seeing what is available, what is open, what could be provided to clients.
Great. Okay, thank you.
I see Tara have her hand raised. Tara, would you like to come off mute and ask your question?
Hi. Yeah, thank
Hi.
you. Hi, everybody. My name is Tara Pavo, and I'm the Director of Social Services at Mary Center. And I do want to share that we've actually started implementing one of your suggested recommendations, which is to partner with community agencies. Mary Center often gets sought out to, hey, can you, sign this agreement where, can you support us in pursuing this project, this funding? And I, refer to us and we'll refer to you. And so I've taken lots of these conversations that folks have addressed, that community agencies have addressed us with and wanting to get into these MOUs and agreements. And I've said, okay, that's great. We support your cause, but all this comprehensive care coordination that we do and that we're fortunate enough to do, that you're now asking maybe 10 hours a week for us to do, which is now 25% of a staff's time to do. I've been really adding, like, our costs associated. It's going to cost maybe about X amount of money to do this for your 50 clients you'd like to refer. And I've started really taking the support approach, because asking for money is uncomfortable, right? Nobody wants to ask for money, especially community agencies, nonprofit agencies, and all this stuff. But since I've taken this more direct approach in December, I've had 3 agencies like, okay, well, let's talk more. Let's dig a little deeper. And I'm like, oh, okay. Like, did I ask too much? Did I ask too low? But I just wanted to say, like, it's gotten us 3 opportunities to go to the table. Nobody has said yes yet. I have not gotten a check, but it's opened up opportunity. So I do want to share that it's been pretty successful. And and the worst they can do is say no. I mean, we'll still support your cause, but it was worth a try.
Tara, any other questions? Okay, so I can just add a little bit, because we work closely with CHW2 here at the health department with the prevention link program. And so we do have one of our CHWs is also a lifestyle coach, which we do see the benefits of that. And we are planning to roll it out to our other lifestyle coaches also. And I think some of the challenges, like was mentioned in the presentation, like the proper training, additional training, because various programs has different requirements and working with a different population. So just also, I think, like making sure the CHWs have that training and based on the population that they're serving and which chronic disease the patient may have. I think that additional training is definitely a benefit. And I know we have some CHWs on the call. I don't know if they have any comments or any input. I think this presentation was very well put together and a lot of research been put into it. I learned a lot. Actually, I didn't know about the crowdfunding, so that was very interesting. I started looking into the community care hub and how we can leverage that now since we have the umbrella hub. So definitely some key points that took away from this project, and I plan to, move forward with the Prevention Link program. But I know Shirley is on the call and some of the CHWs, and Caitlin, I don't know if you have anything you would like to add. Okay, I'll turn it over to Dr. Carter because I'm sure he has something to say.
No, I really appreciate this presentation. I know that it aligns with our thinking. And as you said, Twanisha, there are some of the suggested sustainability pieces we have to consider. I mean, because we're going to have to do something in our county to make sure we sustain our community health workers. And the other part I really appreciated was we get input from our community health workers, but to have it organized and to understand that we need to have a system that makes our community health workers feel appreciated, know they have a path forward, and that they can go from community health worker to the next step, whatever it is, whether it's nursing, case management, whatever it is, in the healthcare system. They need to be able to see a path, especially in public health. And every time I turn around, I'm hearing the fact that we don't have enough public health infrastructure, we don't have enough public health workforce, yet we have community health workers that we're training who could advance into these positions. And especially when I talk to CDC, although they're not talking to us right now, but when I talk to CDC, they they are talking about how we should be developing these pipelines. We have the opportunity. And I will just say that we do have, even though it may not seem like it, but we do have a unique opportunity now to advance what we're doing and to try to get it so that we can develop sustainable programs for our workforce, especially our communities where people need the work and we need the effort. So that I can't thank you all more for this presentation. I really would like to thank you. I know we're coming close to time, like 1 minute. So I would like to just go straight into the head it over to Taylor for community announcements, and then we'll wrap up.
I can jump in on this one, Taylor. So we have, so yeah, I'll cut it short because I know we're pretty much out of time, but HQI, that was incredible. I also want to definitely thank all of the partners and CHWs who participated. I'm really grateful for this frank and honestly damning at sometimes information about the environment we've created here at the Prince George's County Health Department, and we have some work to do. So I really do appreciate that. I did want to make sure that everyone was aware also through the CHIS program, we pay for slots for people who are interested in becoming community health workers to complete the core training for the state of Maryland. So we contract with IPHI right now to offer those CHW training services. I've heard excellent things about their trainer, who I believe used to be a CHW herself. It's been a good experience for our CHWs who have gone through this particular training. We're launching our next cohort on, we did delay the date a little bit because our enrollment is very low, has been very low. So it's February 10th through April 14th. It's fully paid for. It does cost about $5,000 to $6,000 per student. So, you know, this is a benefit we're offering for anyone who's interested in this as a career pathway. So please sign up if you're interested. Please share also with other organizations who may have folks, you know, we'd like to think about those people in the, you know, those people at church who you kind of look to for health information, or, you know, everybody has somebody in their life who they know always has the scoop on health related things, who we go to naturally. So we're looking for those people, and we'd love to have them trained formally to kind of to do this work. So thank you so much, and happy to answer any questions anyone has about this.
Any questions about the training?
No, I was going to, I'm going to send that in the chat. Can you email this information to me at my email address, please? Because I do know somebody that's looking for to finish their training program for this.
Absolutely. I will send out the flyer and folks can scan that QR code. And if there is a link folks want to put in the chat, we can also have that available. Any additional questions? All right. And next, just want to remind folks of 2 surveys that we have out. First is a feedback survey about this work group in particular. So what you all want to achieve in the new year. We'll ask some questions about how facilitation was in 2024. So in our next meeting, we'll talk about our next steps as a work group and what we want to accomplish. So we could use your feedback and what you all want to focus on. If there were any points in this presentation that you want to highlight, do feel free to mention that. And then also we have a partner survey for all of our coalition members that we are asking folks to complete by the end of the month. It will ask you questions about population served, your services provided by your organization. So again, we want to build up a better partner directory and be able to spread information about different folks who are represented in the coalition and figure out our gaps as to who we are missing and need to invite to the coalition to have more voices heard. So I will follow up with links in the email that I send out to you with the meeting minutes and the meeting recording. But otherwise, does anyone have any community announcements that they would like to share? All right, well, we will convene next on Thursday, February 27th at our usual time at 11 a.m. I will send out the meeting minutes, but feel free to let us know if you need anything in the meantime. And Miss Denise, I see your hand. Okay. Sounds great. Well, thank you again, everyone.
Thank you.
Thank you
Bye-bye.
all.
Thank you.
Thank you, everybody. Have a good day.